Good evening, everybody. My name is Terry Axelrod. I've been asked to host this fireside session this evening with the topic being that of elbow fracture dislocations, commonly known as the terrible triad injury. We have a nice group of people that are going to be helping us with this. We're Jonah Davis from University of Washington Medicine, Harborview, Greg Della Rocca from Missouri University Health Center in Columbia, Missouri. The format of the session will be like the previous fireside discussions. It's going to be case-based. Each of the faculty members have one case that they're going to present in depth. And it's really important for us to get as much feedback, question and answer from the audience. Apparently we have about over 400 or 450 registrants for this session this evening. And it'd be great if everybody would use the Q&A box at the bottom of their screen to ask questions as we go along. Most of the questions we'll be able to answer either through the Q&A box or as a live answer as part of the discussion. It'll be fairly informal, much like the traditional AO Firesides have been in the past when we could do these in person. And hopefully it won't be too long before we'll be able to start doing these in person as well. So this is some of the meat and potato slides that we have to always go through about conflicts of interest. So for Jonah Davis, myself, there's no financial relationships or conflicts, and Greg Della Rocca's potential conflicts are listed here. Yes. So when we talk about the terrible triad injury, there are specific learning objectives that we want to cover during this next hour, an hour and 15 minutes. So we want to first of all be able to recognize the radiographic features of the terrible triad injury of the elbow. We have to fully understand and interpret the soft tissue elements that contribute to the elbow instability associated with these injuries. It's paramount to understand that this is not just a bony injury. This is an injury that involves extensive amount of damage to the soft tissues about the elbow, allowing it to dislocate and become chronically unstable. The next step of the learning objective is to be able to describe the steps needed to stabilize the elbow surgically following the terrible triad injury, and then what to do when things go wrong. And that's going to be the last learning objective. So to describe the next steps in management when faced with a persistently unstable elbow after you've done everything more or less correctly. You've done the standard approach and yet it remains unstable. So those are the learning objectives. I'm going to lead off with a quick case. We're not going to do a lot of discussion over this one because I want to save the discussion for our other two faculty members. This is a 21-year-old male who, through a suicide attempt, jumped some 10 stories. He had bilateral open elbow injuries, a femur fracture and a closed head injury, and we were asked to manage his elbow injuries. So this is the supposed closed reduction x-ray of his right elbow, and I'm going to show you the left, which is the one that we're going to talk about. So this is after a closed reduction, and it was a typical fracture dislocation. But I think most of you would notice that there's something missing in the middle here, and that's the radial head. It doesn't seem very obvious where it is, and there's a bit of a fracture fragment sitting anterior to the coronoid here. The elbow appears to be reduced on these films, and this is the PA projection, the same, and you probably can pick up this round structure, which is the radial head, having been split into 2 or 3 pieces and dislocated laterally. So a CT scan was done, and you can see the difference on the CT between a relatively congruently reduced elbow joint at the time of these x-rays versus a subluxed or nearly dislocated elbow at the time of the CT, which was done just within an hour of those plain elbow x-rays. So this just gives you some idea of the magnitude of instability of this type of an injury. So what did we do surgically? Exposed it laterally, followed by a medial exposure. I did the typical repairs that we're going to talk about over the next hour, repairing the bony and soft tissue structures, including the anterior capsule, the lateral collateral and the medial collateral ligaments. And on the left side, which was the one I was just showing you, I did a radial head arthroplasty rather than doing an RIF of the radial head and neck. An examination under anesthesia under fluoro in the operating room was done for both elbows, and both of them were surprisingly stable following these repairs. So nothing else was done. And this is what it looked like post-operatively, relatively well aligned, not overstuffed. The arthroplasty seems to be sitting well. Perhaps the splint could be flexed a bit more, but it was pretty good. And then, of course, the story doesn't end there because this is a webinar and we have to discuss when things go wrong. So he was brought back to clinic at 2 weeks for a cast change, and he had this really nasty head injury from his fall, and he was very difficult to control. And after we had changed his back slabs to a fiberglass back slab, he was sent for check x-rays, and these are what they look like. So despite it being stable intraoperatively, not so stable at 2 weeks post-injury. So we're going to go on from that as to what we were going to do next, but we'll come back to that a little later on in the discussion. So I'll introduce Greg Della Rocca, and Greg's going to take over with his first case now.
Thanks very much, Terry. And it's a pleasure to be here. I hope that we get some good things from this. So my case is a fairly straightforward case that I'm going to discuss. So the patient is a 30-year-old male. He fell on an outstretched left arm. It was a fairly straightforward fall. He only fell about 2 meters, so about 6 feet, a little bit more. He's a right-hand dominant guy, pretty active, 30 years old, works in construction. This is an isolated injury. He has normal neurovascular function in his hand on the side of the injury. And he doesn't have any laceration, so this is a closed injury. So this is what we are looking at currently. So the patient was brought in with an obvious elbow deformity, and he was brought to the emergency department with substantial amounts of pain. And this was the index image that we obtained. And what you can see here is that it's fairly clear that the elbow is dislocated. Okay, so there may be other things going on, but I would say that the first thing most people would notice is that the elbow is dislocated. So you can see the distal humerus and the forearm do not have a normal relationship. So this is an attempted Greenspan view. As you can see, I would say it looks more like a regular lateral image. But I would say that this image gives you a lot of information. So if you look at the image, you don't even have to look at this image very closely to identify the empty greater sigmoid notch. So, and what that is basically, if I can go ahead and I'm going to try to let's see, I'm going to try to do a spotlight here so you can see an empty greater sigmoid notch here, which is pretty obvious, right? So the ulna is dislocated posteriorly, and this is where we start off. But if you notice that that's not the whole story, and obviously this is a terrible triad seminar, and so it's not just going to be a simple elbow dislocation. So if you look right here, adjacent to the red highlight, which I hope you all can see, you can see that there is a small fleck of bone that is present just superior to either the trochlea or the capitellum. It's hard to know which is which on this image because it's not a perfect lateral of the distal humerus, right? But you can see that there's a small fragment of bone there. Okay, and so this would, this almost always is going to be a fragment of the coronoid. And it's important to notice that because missing these is actually a really bad problem. Okay, so if you treat this as a simple elbow dislocation, you reduce it, and you actually get it to stay reduced, which isn't always possible. Then these will tend to have difficulty later on, and they can have persistent instability. And the main reason is that that coronoid fracture is really kind of it's a sign that there has been a basically removal of the check rein, that's the anterior capsule that prevents the elbow from dislocating posteriorly. So don't think about it as the coronoid being fractured and you lose necessarily the buttress against the elbow dislocating posteriorly, which does happen. But think about it more along the lines of that that coronoid fracture fragment is a flag okay, and it has anterior capsule attached to it. And that's the big problem with these. So if I can, let's see if I can take the spotlight off here. Okay. So this was an attempt at reduction. We all happy with that? Looks pretty good, huh? So elbow's not quite as deformed as it was. So I can see Dr. Axelrod is really happy with that. So I guess a question would be, is it worth an attempt at reduction in the emergency department, or should we just leave the patients dislocated? And recognizing that this isn't going to be something that we generally would send home, we're going to take it to the operating room to do something about it. I would suspect both Jonah and Terry would agree with that. So should we even try to do a reduction in the emergency department? So any thoughts about that?
I mean, I'd say, oh yeah, go for it, Terry. Sorry. No, go.
Jonah, go.
Okay. I'd say we, two things. One, looking at your post-reduction, there's no splint and there's still fingers on the arm that you can see. So I suspect the person didn't think that this was very well reduced. I think it's worth it because these are often not life-threatening injuries. And unfortunately, at least at our institution and a lot of trauma institutions, it's hard to justify passing this in front of a open femur or an open tibia or something like that, right? So I think it's worth getting it reduced because we did a paper out of here, and a lot of other papers have looked at it. You know, the longer something is dislocated, the more times it's dislocated, the higher risk of HO and traumatic soft tissue injury. So I think for that reason, it's worth getting it reduced. It does often need better sedation in the emergency department. So this is one where I don't hesitate to bring them down to the preoperative area, have the anesthesiologist put them to sleep, even with a LMA or something, and pop it back in, get good C-arm, because oftentimes the ED docs are unwilling or unable to do that amount of sedation, and they're a little bit afraid to do it. So I think it's worth it. You temporize, everything is much less of an urgency if you can get it in. Then you can handle it sort of during the daytime or in a good time. Maybe the elbow person can do it or something like that. You know, so I think it's definitely worth it.
Yeah. So another thing that Jonah didn't exactly point out. I mean, he did. You do see there's a lack of splint. You see there are a couple of digit tips there on the medial side of the humeral shaft. But what most of you will notice is that it's a pretty good AP of the distal humerus, and it's a pretty good AP of the proximal forearm. And so that's an elbow that's extended. And we know that terrible triad injuries are more unstable in extension. So why, I mean, I won't throw anybody under the bus, but you know, if you're going to assess a reduction after you reduce a terrible triad that you've identified, probably extending the elbow completely is just going to cause them to redislocate, which appears to have happened here. So
I would just, Greg, echo what Jonah said, that I think there's nothing to be lost by a closed reduction. And there isn't always an elbow person, somebody who's comfortable with dealing with this available on a moment's notice. And sometimes, like in our institution, like at Harborview, or the same as I'm sure at your place, they don't often get done for a day or two, or even perhaps longer. And so you don't want to leave the elbow dislocated that long and then get into problems, compartment syndrome, neurovascular compromise, that type of thing. So pop it in, keep them immobilized at 90 degrees. And usually that's good enough. Then you can get advanced imaging and you can not semi-electively, but you can put them on the list as a more of a C type of case.
Yeah, and I agree with that. I agree with that completely, because the other thing is that, these, I mean, I see plenty of these patients that have these injuries are not the isolated injury. I think Jonah already mentioned this. I mean, these happen in patients with other complex injuries, and the elbow may take a back seat to other life-threatening injuries. And so if you leave them without an attempt at reduction for an extent, you don't know when you're necessarily going to get them to the operating room. It could be 5, 6, 7 days, 14 days. And let me tell you, if you have a fracture dislocation of the elbow that's been out for 14 days, that's an atrocious slog to get that back to where it needs to be. It takes a relatively straightforward surgery and turns it into one that's totally not straightforward. So if you see, they did we did a repeat reduction attempt, and this looks much better. You will notice that I'm going to go ahead and attempt again to pull up a spotlight here. But you can see here, there's a fairly substantial sized piece of bone that if you look, it's just underneath my spotlight here. If you look, it's adjacent to the radial head, and the arc almost looks identical to the radial head that's adjacent to it. Okay, so this is a radial head fracture here that you can see. So this was the part of the injury, of the terrible triad injury, that may not have been identifiable on the first couple of images that we had with the elbow still dislocated. So the terrible triad, of course, is a dislocation of the elbow with a coronoid fracture and a radial head fracture. The dislocation is usually posterior. And that gives you some ideas of how we're going to be approaching this. Again, the radial head is going to be something that we're going to need to consider what we're going to do about it. The coronoid is really a flag that tells you, hey, here's an anterior capsular avulsion, and that's what we actually will probably need to address. And then the ligaments that are torn are going to be most likely the medial collateral ligament and the lateral collateral ligament. And so those are going to be the ones. Those are going to be the ones that we're going to need to address. And then the question is, how do we go about doing that? So what I just said. So a terrible triad, as most of the audience is aware, is a posterior elbow dislocation most often. Tip of the coronoid. It tends not to be a very large piece of the coronoid. However, Terry, can you hear me? I'm getting word that my internet connection is unstable.
You blanked out for a second there, but it's come back. It's fine now.
Okay. All right. My apologies. So the coronoid fracture is most often a coronoid tip fracture, what might be termed a Regan-Mori type 1 fracture. But really the importance of the coronoid fracture is that it represents a capsular avulsion. So what is our plan? So I'm going to go back one slide. And Jonah, do you have any particular thoughts about this? I recognize that this is a relatively more straightforward case here.
Yeah, I have a few thoughts. One thing that we didn't really talk about, and I think sometimes it's interesting, is other imaging that I might get. And I am a very big proponent of CT scans for most injuries. And I'm often ridiculed and made fun of by some of my trauma colleagues at other institutions like Mike Gardner or Tim Aker for getting too many CT scans. They say I must have I must be on the take with the, Phillips or Siemens or whatever. But I think that when you have a well done CT of the elbow, and that just takes a little conversation with the CT tech so that they cut it in the right format, or they reformat it in the right planes. I think it gives me a lot of information. One, I get to better see where that or what the size of that coronoid fragment is, if I'm going to fix it with screw, with a plate, if it's just going to be sutures, if I need to fix it at all. I get to look at the radial head and I can see, is there one piece, two piece? Sometimes you can see that on the x-ray, but then you can see impaction. You can see, oh, maybe there's an extra piece I didn't see. Maybe there's something there. And then in the joint, I can look if there's any fragments, right? Often you said these are dislocated posteriorly, and when they come back, they leave fragments in the joint. And you may wonder why you have a fat joint or ulnohumeral joint that's not reduced all the way. Well, if there's a fragment in there, then for me, I like to know that I have to go get it. And I know, okay, there's 3 fragments on the CT scan. When I'm in the OR, I pull out 3 fragments, I've got all of them. And that usually leads me to have a better thing. So that's the one thing. I think I would get a CT scan to better evaluate this. And the other thing is, we do these in hospitals, it's easy. But if people are doing these in surgery centers or places where they may not have every, different implant, it makes a difference to know if you're going to do a replacement or a fix, and you have to have all those implants. And so that is easier to do with a CT scan, at least in my hands. So that's the first thing I do. And then I decide what needs to be fixed. I have an order that I go to, and I'm sure we'll go through it later, but figuring out if I'm going to fix or replace the radial head, figuring out if I'm going to fix the coronoid, and then determining stability, fixing the lateral side, determining stability, fixing the medial side, and so on and so forth. So I think that's the first big lesson, would be just figuring out exactly what I have so I can determine my plan.
Yeah, so I'm in, I'm in substantial agreement with you. I think that we have to be careful about thinking that these are as straightforward as we may think. The coronoid fractures sometimes are comminuted, and the CT scan will tell you that. But you see here that I've put up an arrow, and I'm particularly pointing to the radial head neck junction, which for the part of the radial head, if you look closely, for the part of the radial head that seems to be intact, it actually doesn't really look intact. The junction between the radial head and the radial neck inferiorly, or sort of, at the towards the bottom there on the X-ray, looks a little bit more normal, but on the top, it looks like it's been squished in. And I think that's something that's important. So just recognizing that there's that one extra fragment that's floating free, and you could say, oh, that's a big fragment, we can fix it. But leaving the radial head oriented in the wrong direction is just almost as big of a problem as it is to just take it out, which we don't generally do, right? For a terrible triad injury, we don't remove it. So if you are having trouble interpreting your images, getting a CT scan is absolutely the right answer. And why wouldn't you do that? And the funny thing is, I think it's funny that people make fun of you for that, but the truth of the matter is that if you find that you're getting a CT scan and you never get good information from that CT scan that you didn't already have, then sure, you should probably ask yourself why you're getting them. But it's not like a badge of honor to be able to wade through these complex elbow injuries without a CT scan and then beat your chest and say, yeah, look what I did. I'm awesome because I didn't need a CT scan. If you need a CT scan to understand the injury, and then that will help you with your surgical tactic to fix it, well, then shoot, you should totally do that, And so I love how people get really up in arms about, getting CTs and things like that. I don't necessarily think that just randomly getting CTs is the right thing to do. But that being said, if you get good information from it, then you should totally do it. I agree with that completely.
Can I just add one thing to that, Greg and Jonah?
Yeah, sure.
I 100% agree. Even up here in Canada, where we're very cost conscious about everything, we would just get a CT at a drop of a hat for that, for any kind of elbow injury like this, where we're a little bit unsure. It isn't even rather a matter of unsure. I know what it is, but let's say there's a fairly large shear fragment to the medial coronoid facet that I wouldn't normally see that on an X-ray. I would only see it on the CT. Then I'm going to plan in advance that I'm definitely going to need to do a medial exposure. I'm definitely going to need a little 2-0 buttress plate or something like that to hold that fragment in place. That would be a little different approach than trying to do it all from the lateral side if I knew it was just a little Mori type of one coronoid tip shear fracture. So I agree 100%. Get a CT.
So it turns out that this guy's coronoid fracture was a small single fragment tip of the coronoid fracture. His radial head fracture was one large fragment that you could see that was displaced. And then there was impaction at the radial neck of the remainder of the head. And there were a couple of other small fragments that existed. So what would the plan be then? So if we're going to tackle this operatively, I'll just go ahead so we don't use up too much time, and because we got some other great cases. So the plan in general for a terrible triad injury would be repair of the anterior capsule or repair of the coronoid. So really the coronoid repair is just a surrogate for an anterior capsular repair. And that is the goal, is that you're restoring that anterior check rein that has been disrupted by the injury. The radial head, you're going to either fix it or you're going to replace it. So one of the reasons that terrible triads may be so named is that not only are they awful injuries and there are 3 things wrong with them that but maybe the surgical management of them, like historically, was resecting the radial head, which just made the elbow even more unstable. But now you've operated on it. Now they get infected, and now they have an infected and unstable elbow, and it's just awful. And so maybe that's part of the reason that the terrible triad is what it is. It's just because it's such a, it was a poorly understood injury. And we're going to hear a little bit about some of the seminal literature that helped us to understand this in a little bit. So we're going to either fix the radial head or we're going to replace it. And I have a very low threshold for replacing the radial heads, even if it gives me nausea to do so in a 22-year-old. I would rather have somebody with a stable elbow than have somebody that has very tenuous fixation, because that radial head is going to protect our coronoid repair. And if the radial head falls apart, then the coronoid is going to almost certainly fail as well. And you're just going to end up back with a bad problem with these patients. So I do everything I can to fix them, especially in younger patients. But if I can't, then I don't hesitate and I'll replace it. So I always have the replacement devices available for me when I'm taking care of these injuries. I will repair the lateral collateral ligament on the way out, and then I make an assessment of stability, just not by doing stress examinations, but by just taking it through ranges of motion in pronation and supination, and then I'll go over and repair the medial collateral ligament if the elbow is still grossly unstable. And so this is
Greg,
sorry.
I'm just going to bring up one point there. When you talk about fixing the radial head, one of the problems is if it's a radial head and neck combo, it's really difficult to get that angle correct, the normal perpendicular axis of the proximal radial shaft to the head. And so often you see people that have done a really tremendous job of fixing the radial head itself, they don't get the angle quite right. And so, like you said, it ends up looking much like your pre-op x-ray looked, where you have this angular deformity at the neck shaft angle. And I think that creates its additional problems and doesn't really contribute to the stability of the elbow that you really need. So I would want to ask you and Jonah, do you have a number of pieces generally that you work with? Like you say, oh, this is 3 pieces, I'm not going to fix it. Or this is 5 pieces, I'm not going to fix it. Jonah, what do you think?
I don't have a cutoff. Probably more than 3 pieces starts to be a little bit complicated, but it's also for me the thickness. So if the fracture is a very thin pieces and the screws are going to have to hold that up, I don't feel great about how that fixation is going to hold up. If it's a case like Greg's where there's impaction, and now I'm asking the plate to hold up the impaction because I'm restoring that angle, and on top of that, I'm asking to act as a secondary stabilizer of the elbow, you're going to doom the fracture to failure, and then that fracture is going to fail and it's going to doom the stability of the elbow. So I think probably 3 pieces and, more than 30 degrees of impaction, where when I restore that normal angle of the neck shaft angle, then I have to bone graft or something like that. I think for me that's probably the indications to go to a radial head replacement.
Yeah, that's great. That's pretty much what I would say. Greg, any thoughts on that?
Yeah, I don't have much else to add. I mean, I don't mean to be nihilistic about these radial head fractures, because I will try to fix them if I can, especially in a younger patient. But boy, the tolerances to for some of these fractures are really, really tight, and if you get it wrong, then it just doesn't do anybody any good. And so but I agree with Jonah. I mean, I prefer to have it, usually the ones that I'm fixing might be 2 or 3 pieces, but if they're only partial articular fractures, those are the ones that I would be more likely to fix. If I have 2 or 3 pieces that are off and the other part that still seems to be attached to the radial shaft appears to be impacted, those are the ones where I'm pretty quick to punt to an arthroplasty, just for the angular reason that Jonah mentioned.
So Greg, one of our participants asked a question, how to approach these injuries, a single or a double approach? What do you think? One incision down the back or separate medial lateral? I know this always comes up whenever we talk about these injuries.
So that's a great question, and I'm glad that it came up, actually. So there were historical recommendations that if you needed to get to both sides of the elbow, that you could do it from the back, and the back the window to the front of the elbow is through the back. I think that was something that was popularized maybe 20 some odd years ago. I'm not sure that that's necessarily the case. It doesn't make sense to me to approach this type of an elbow injury from the back when you're staring at an intact ulna, where the only thing that's fractured on the ulna is anterior. Going from the back just doesn't seem like a great idea to get access. Now you can do it. You can, I mean, shoot, I tell people that I don't need to put vessel loops around nerves, except for maybe when I'm dissecting them out, because I can always find the nerve and I can get to the nerve from wherever I want to. So I can always find it. I can get to wherever I need to. The question is, how much damage do you have to do to do that? And one of the things that's a problem around the elbow is raising these massive cutaneous flaps that you sometimes end up needing to do in order to get to where you're going. And then they fill with hematomas, and then patients get stiff and maybe they get HO. I don't know whether it contributes or not to have these huge cutaneous flaps, but I would suggest that for this particular type of injury that we're talking about now, I would suggest that the bulk of the time I'm going to do this through an isolated lateral approach. And I usually use a Coker approach, which goes between the ECU and the anconeus muscle. And the reason for that is that takes me right down onto the course of the radial head, or excuse me, of the lateral collateral ligament. I suppose you can use a Kaplan type of interval as well, but that really puts you a little bit more anterior to the LCL itself. It puts you kind of equatorially where the radial head is. But I prefer to be able to have the exposure down onto the lateral collateral ligament. Most of the time, the LCL is avulsed off of the distal humerus, so you'll encounter a bare epicondyle there. Mm-hmm. And most of the time, a lot of time, the dissection has already been done for you. But if it's not, what I often find is that I can, if I trace the Coker interval, it takes you right down over the supinator crest, which is the insertion point for the LCL. And that's where you'll find maybe some fibers, some sort of thicker tissue that you might want to imbricate as you do your LCL repair on the way out. And so for me, that works pretty well. Another question that I often get from my trainees is how I can find a muscular interval in a highly traumatized bed. Well, there's a very, very straightforward way to do this if you're not scared of making an incision that's a little bit longer than you would like, is that you know that the general anatomy of the anconeus is that its most distal insertion is 10 centimeters distal to the tip of the olecranon on the subcutaneous border of the ulna. So if you mark your lateral epicondyle and you mark 10 centimeters distal on the skin, distal to the olecranon tip on the subcutaneous border of the ulna, and draw a line in between there, that's where your incision can go. That's sitting right over Coker's interval. And you can just keep dissecting a little bit further distal until you get to a point where you feel like you've actually identified a plane. And then you can just go ahead and then incise that plane back towards the epicondyle. And that, to me, has been something that I've been able to use. And it just makes sense to me because anatomy makes sense. So, and unfortunately in trauma, as most of you know, anatomy is not always accurate. So.
Good discussion. Jonah, anything to add to that? Are you a more universal posterior, or do you like the separate medial and lateral exposures?
I go lateral only 95% of the time. I find the medial side for acute, simple sort of fractures like this is rare. When you need it, a separate, simple medial approach is probably best. I agree. Raising these big cutaneous flaps, not ideal. I think Sean O'Driscoll is someone who had popularized that, and he's actually gone back to the other side also. So It's very simple. It seems like a weird thing to kind of plan for something that doesn't happen very often to maybe avoid a complication when it actually doesn't cause the complication to go on the other side. So I agree. The other thing is that approach, you know, the Coker sometimes ends up being just cutting the skin and then you're in the joint because it's all traumatic depending on how bad the injury is. So I like the idea of staying intermuscular and, you know, following the Coker interval, but sometimes it's hard because everything is sort of, you know, torn apart. So I'll find the, you know, the tendon, try to work my way in and adapt it into a Coker, but I kind of take what the patient gives me too.
That's good advice. Yeah, like about this incision thing, I don't want to harp on it for too long, but it just, when I used to do it with the universal posterior, I did a couple of times and then I stopped. It just, these really long incisions with huge flaps, and it just seemed awkward and silly. Whereas you can do a relatively short Kaplan or Coker exposure, and you can do 95% of what you need to just through that little, much more little incision right where you need to be. And, you know, we know 2 incisions far enough apart around the knee for a Schatzker 6 tibial plateau is a great way of dealing with that injury. So why would we not want to do that on the elbow as well? So I'm pretty happy with the separate incisions, whereas most of the time I just have to do the lateral side only. Sorry, Greg, we've taken up your time here. We'll let you carry on.
No, so that's fine. So I'll just go ahead and finish up this case real quick. So this is what we ended up doing. You can see, so we did a coronoid repair, which was done through drill tunnels that you can't see. I usually make 2.0 millimeter drill tunnels if for those who are interested in knowing specifics. I use a very heavy braided suture that's non-absorbable that I pass. Often I'll pass it through the coronoid fracture fragment, which is not the easiest thing to do necessarily, but usually I'm working through the Coker interval. Oh, and what I didn't say is that I already resected the radial head. So I knew that I was going to replace the radial head. So I went ahead and I took the radial head fragments out and I made my saw cut. And now I have more room so that I have better access to the coronoid fracture bed in the anterior capsule. And so I pass my sutures through the coronoid if I can. But the most important part of that is a bunch of locked Krakow stitches that I throw into the anterior capsule. That's the part that I think makes a bunch of people freaked out because you're passing a suture through the anterior capsule and all you can think about is what's on the other side. It's, oh my God, the median nerve is there and the brachial artery is there and it's going to be terrible and you're going to cause the patient to lose their arm. But remember that the capsule itself sits beneath the brachialis, right? And so the brachialis is in between the capsule and the neurovascular bundle. And so those of you who have done elbow arthroscopy and have watched arthroscopic releases of the capsule, you know that as they come across the capsule, as the surgeon comes across the capsule, you see muscle on the other side of the capsule, and that's brachialis. And so now that doesn't mean you should be cavalier about throwing needles wherever the heck you want, but it means that you probably don't need to be quite as scared of nabbing the neurovascular structures there. Now, you should be careful laterally if you get too aggressive and you try to weave your suture a little bit too lateral. The radial nerve is in fairly close proximity. But really, if you know what you're doing, then you're staying medial where the coronoid is. And then you pass those sutures through drill tunnels in the ulna. And I usually make a small accessory incision and then I tie the suture down over a bony bridge on the subcutaneous border of the ulna. Then once I'm done with that, I don't tie the suture down. I pass it and I tag it. A big mistake that I made early on is tying down the coronoid and being really, really happy with my repair, and then going ahead and working on my radial head replacement and my LCL repair. And then before I know it, suddenly I'm looking and my coronoid repair has failed because I've been manipulating the elbow. So I'll pass my sutures through the coronoid, through the drill tunnels, I'll tag them, but I won't tie them down. Then I proceed with the elbow still unstable to do my radial head replacement. And then I'll go ahead and put my anchor into what I believe to be the isometric point at the capitellum and pass sutures through the remnant of the lateral collateral ligament and tie. And then only when I'm ready do I tie everything down. And then I basically close the skin and hope that everything's stable. And in this guy, I did not need to do a separate medial approach, just like Jonah has indicated, probably not going to be needed. This is a lateral view. And you can see his elbow is pretty stable there. There's my hyperextended IP joint of my thumb. So in general, do you have any particular recommendations, Terry or Jonah, regarding postoperative rehabilitation?
I'll just give you my 2 cents worth. It's like everything. It's like the open tibia in the middle of the night question. It all depends, right? So if you have a patient with a head injury that's going to be going off to the ICU, that's going to be treated in a very different fashion than a patient who has just got an isolated injury that's cooperative and wants to go along with your game plan. So for me, anybody that's going to go, who's got a head injury, not cooperative, they're going to go into a cast, and they're going to stay in a cast for quite a few weeks, probably 4 weeks or more, and watch how their head injury recovers and how much they're able to cooperate. Because I've been burned more than once on these injuries where you think it's stable intraoperatively, and then, like the case I showed earlier, boom, they come for follow-up and it's redislocated. If it's a cooperative patient, I mean somebody that understands the game plan, I'm going to immobilize them with a back slab for 2 weeks at 90 degrees, not hyperflex, but at 90, where they're comfortable. And then I'm going to put them in the hinge elbow brace at that 2 to 3 week mark and let them start moving the elbow. And my protocol is pretty much the elbow brace at 60. So full flexion is allowed, but they can't extend past 60 for the next 2 weeks. Then they can go out to 45 for another 2 weeks, then to 30, and slowly but surely over a period of 6 to 8 weeks, I get them out into full extension. Just being able to bend from 60 up to flexion relatively early on does help with the rehab substantially, I find. So that's sort of my protocol on that. And I'm not entirely sure that the patients cooperate with that, because they often come back around 8 weeks after the injury and the brace is in a handbag somewhere rather than on their arm. But that's sort of the game plan that seems to work relatively well. Yep. I do try to avoid the varus positioning of the elbow, but I'm not sure they really listen to me on that one. Jonah, any ideas?
I put them in a splint for like 7 to 10 days, depending on how bad the soft tissues are. I then take them out and put them in a 90-degree plastic molded splint that's made by our occupational therapists. And I have them come out of that, and I do supine overhead flexion and extension. So they're using gravity to kind of help them with that. And then I have them do pronation, supination, sitting down at 90 degrees flexed. And then I have them go back into that sort of the static splint just to protect it. And I do the static splint for about 4 more weeks after, so 6 weeks total. I find that the overhead exercises are actually tolerated really well, and they get good motion without sort of degrading their stability at all. It's really well tolerated. And after 6 weeks, then I have them come out of the splint and just range of motion is tolerated. I tell them to avoid reaching for stuff in the fridge because that's the number one thing I feel like people do is in varus. They go and get something and their elbow is up and they have a lot of weight, like a gallon of milk or something. But otherwise, I agree. Patients don't really listen that much. They kind of do what they want to do.
Yep.
Greg, what's your approach to this?
Yeah, I usually have them moving. I put a hinged elbow brace on them immediately. There have been a couple of people where I've been concerned about head injuries where I've splinted them afterwards, but mostly I'm putting them into hinged elbow braces. I assess some degree of stability, and if in the operating room, and I'll sometimes put a 30-degree extension block on them. I don't usually do 60, but there's no good reason for that. And I may consider doing that and then, letting up by 15 degrees every couple of weeks. That sounds kind of cool. But I am very particular about the varus precautions. I tell them that they should only move their shoulder to get their elbow away from their body far enough so they can wash under their armpit when they take a shower. And they seem to understand that if I tell them no more than 30 degrees of abduction, they're going to look at me like I'm from Mars and I have 3 heads, because they won't understand what that means. If you kind of give them an idea of sort of a motion that they would do on a fairly routine activity of daily living standpoint, they'll be able to understand it. At least that's what I found. Yeah, and I tell them to avoid just like Jonah said, I tell them to avoid the varus positioning. I don't say it like that, but I mean, reaching into the refrigerator is a big thing. I always tell them to consider wherever their arm is, that their hand should be above their elbow. We don't want the hand to the side of the elbow. We want the hand above the elbow, towards the sky or the elbow. So if they are going to bring their arm up like this is probably okay. I don't know many people are going to do this about 3 days after they have a terrible triad fixed, but they might. But in reality, there's no varus moment on that elbow. Now there is, so I don't let them do that. So I just kind of show them that, and they probably think I'm foolish for the gesticulating I'm doing, but I think they get it. Who knows?
All you can do is try. Honestly, all you can do is try. And if they choose to follow your advice, great. If they don't, well, so be it. So we're going to move on. Jonah, I'm going to ask you to show your case now, if that's okay.
Totally. Okay, so a lot of the same points from the last case. The only difference in mine is that I was not in charge of it at the beginning. So this is a 23-year-old patient who was seen at another hospital about an hour south of here, and fell on the ice or sidewalk and had this distal radius fracture. And she was treated for the distal radius fracture and showed up to the clinic at the post-op visit and was found to have pain in her elbow. So they got an x-ray and they found this. And it's a little embarrassing, I guess. And so maybe Terry, if this was picked up in Toronto, maybe it was operated on at the other hospital we don't want to talk about, but if you saw this post-op at 10 days, what's your first thought for treatment in the clinic?
At 10 days, I would, like we talked about, I would get a CT on this right now. I don't think that I would actually try to do a closed reduction on this in the clinic because it's probably not going to go. It might go, but then it's not going to stay. And I'm not sure you've gained much by doing that. I would, however, schedule the patient after the CT for surgery on the elbow pretty much as soon as possible. It's not something you want to wait on. Like Greg said earlier, the longer you wait, the harder they are to reduce and the more mushed up the ligaments are in terms of trying to repair them. They get soft and gelatinous and there's very little to work with. So at 10 days, I start to get worried. It's even worse a week later or 2 weeks later. So just get on and fix it. I'm not sure I'd do it at 2 in the morning, but I'd be looking for a OR time the next day.
Okay, I agree. You're not in a good situation in the clinic to kind of, it's different if they're in the emergency department, you can get them sedation, everything. In a clinic, it's kind of hectic. There's not a lot of, personal space and getting them, sedated and all that. So I think it's very difficult. Greg, would you guys do anything different? Same.
No, I don't have anything to add. I think at this stage, it's important to get the patient to the operating room as quickly as possible. This might be something that if I saw this in my clinic, I would get a CT scan that day, admit them to the hospital that day and try to take them to the operating room the next day because just every day for these just gets more atrociously painful. So for the patient and for the surgeon.
100% agree. So obviously these people watched our webinar and did exactly what we talked about, right? So no. So they did an attempt at a closed reduction, resplinted, and obviously didn't work. And so then they did an open reduction. And so now this is at 3 weeks after that open reduction. When the patient comes back to clinic, you can see there's like a little bit of a splint left over, the bias. And, obviously here they're still dislocated. So now what do you do? Now it's been like they tried an open reduction. They went in there, unclear from their operative note what exactly they did. They saw something there and they kind of just, piecemealed it together, repaired it, put it in a splint at 90 degrees. And now this is 3 weeks after that. So now we're at almost 4.5 weeks. And they decided to try a second reduction and repair. And I can show you the x-ray, but it's exact same. It looks exactly the same, but with, just a little bit more callus formation in the joint. So now, Greg, you do the exact same thing. Would you admit them and try to get them in the operating room the next day?
Yeah, I mean, yes. The answer is yes. I mean, I guess once you're out about 6 weeks, I guess getting them there the next day versus 2 or 3 days probably doesn't make as much of a difference. But yeah, I mean, it's an atrocious problem, and you've got me feeling really bad for this patient right now, and especially knowing that you were sitting up the road the whole time, just sitting by the phone waiting for it to ring. would have been really nice for this patient to have had that happen.
I 100% agree. So, I think this is a summary. This case is now, it's a missed terrible triad that's now had 2 surgeries of unclear, sort of determination of what they did. Obviously didn't work. She's now 4+ weeks from initial injury. And so maybe, I know, Terry, you kind of know what, what's going on here, but what worries you looking at this x-ray? Obviously it's, the dislocation, subluxation worries you, but what more, more than that, what worries you when thinking about this kind of case?
There's a couple of things that worry me. One, I'm not sure if it's the plaster shadow overlay, but it looks like there might be a little bit of HO starting to form around the elbow on that previous x-ray that you showed. That's not a good sign at all. That tells you that everything is just massively swollen inside and there's this new bone being deposited. Some of it is going to really make the reduction almost impossible. The other thing that's worrisome is that if you look at this PA x-ray, the capitellum looks pretty absent to me. I don't see a nice outline for it. I see 3/4 of the trochlea or most of the trochlea, but then the radial head's not really up against anything. So has there been some erosion of the capitellum with that radial head being out for so many weeks? And I think we can see it on the lateral x-ray. And again, a CT scan would really help with that. But the radial head's been eroding up against the capitellum there for a few weeks. And then that makes a situation where even when you're doing your open reduction and you're going to do your ligament repair, et cetera, you're going to have a bony defect, which is like taking out a radial head, only it's on the capitellar side. So it's going to increase the instability. The other thing that worries me, I mean, I know that I can do enough to get this reduced, but the question, of course, is how to hold it. I mean, other people have tried and it's not going to stay in joint by itself. So we have to think, well, am I going to need something to augment those ligaments? Because the ligaments are not going to be ripe for primary repair at this point. There's already been some attempts to do that. And at 6 to 8 weeks down the road, they're just mush. There's nothing to the ligaments that you can fix. So you have to think about augments. So are you going to use a semi-T? Are you going to use a gracilis allograft? Are you going to take their palmaris? What are you going to do to repair the ligaments? And will you have to do a reconstruction just laterally or both laterally and medially in this case? So this is a pretty complicated case. And then, of course, once you've done all that, you need to supplement it with something else to just make sure it stays in joint. Rodrigo Bolognese from South America on one of the questions had asked about a big K-wire or a Steinman pin across the joint. Robin Richards, one of my teachers and one of my partners over the years, used to do that fairly routinely, jam a giant pin up across the olecranon into the joint. It would hold them in joint, but at a cost, right? So we now have better ways of dealing with that, which you're going to get into as you present this case.
Yeah, exactly. And so I just show this lateral to see that the radial head is really lying right on that capitellum, on that posterior capitellum. So I agree. Greg, what's your cutoff for reconstruction versus repair? When do you start to get antsy about doing just a repair on the lateral side? How do you counsel patients on that?
Yeah, I mean, it's hard, and everybody, I think, on this webinar, both participants and panelists, know that every individual patient is going to be different. But once I'm about 3 weeks out, I get I'm really pretty nervous about the quality of the tissue that I'm going to be able to repair. And so I may make some type of a champion's try, or maybe an amateur's try at fixing the ligament if I can. But I'm almost always going to turn to some type of an augmentation, whether it's either autograft or allograft tendon, or some type of an internal brace. I know that the internal brace, so that is a proprietary name by one of the companies that makes it. But the idea being that it's basically a suture tape that is designed to reinforce or substitute for the absent lateral collateral ligament. There are some other devices that I would consider, but I might also be considering at this point trying to imbricate some of whatever tissue I can, and then instead of going and putting in all sorts of $1,000 internal braces, I might be just interested in putting on a relatively less expensive static frame for these to hold them in once I've gotten the open reduction done and to protect the repairs. And then I get them moving after. It's not ideal, but
How long would you keep that static X-fix on?
I'll keep it on for about 4 to 6 weeks.
Yeah, I used to do that as well, and I still will do it very, very rarely if it's a totally unstable, associated distal humerus with a, very bad fracture dislocation. But I think those are all really good options. And one thing that was mentioned in the chat, but maybe not live, is always with multiple surgeries from outside hospital, I think, is there an infection? Is there something like that? So all of her skin was normal, no erythema, no elevated markers, but still always think about that, especially if I'm thinking about putting more metal and more allograft, so cadaver bone or cadaver tissue in there. So it's definitely something I'm thinking about. So that's it. So let me show you what was done. So here is a fluoroscopy with it reduced. So first things first is when you have these sort of chronic or semi-chronic fracture dislocations, the problem is getting it reduced takes time. Greg alluded to it. You have to actually do a capsular release, an elbow release, prior to getting the elbow back in. So you're actually destabilizing it first to get it back in, then you can get it reduced, and then you got to build back up from the ground up. And I think that's really quite challenging. But so once we did all that, was able to get it reduced, you can see that the posterolateral aspect of the capitellum is just missing. It's just gone. And so one of the things I worry about, especially in this type of pattern, is that it's going to act a little bit like a Hill-Sachs in a shoulder, where there's sort of that bone is missing, and now, or like a Bankart even, that bone is missing. The radial head is going to want to just flow right back into that defect. And so I'm trying to think about ways to prevent that from happening. And so again, like Terry talked about, this is 4+ weeks out. I'm going to do a reconstruction. I plan to do a lateral reconstruction. And because there's a little bit of subluxation and opening on the medial side as well, I plan to do a medial reconstruction too. And I usually do that with a docking technique, go into the ulna, I make bone tunnels, I pass a weaved semi-T or a gracilis. I usually use one, cut it in half, and use each half on either side. I weave the Krakow on one side of the stitch, pass it through the bone tunnels, and then I determine where the isometric point is, and I trim the remaining portion of the ligament or the tendon, and then I Krakow weave the other one. Now, the problem is, in this case, I thought I would like to use an internal joint stabilizer, which is again a brand name, but a sort of an internal hinged fixator. And because of that, you have to put that pin in the isometric point. So you have to just think about how to do that. And I've gone to using suture anchors and laying that sort of around the pin, so that the pin can, very importantly, stay isometric. Because if you're going to be moving through the pin, you have to make sure that it's isometric, but that I can still get the ligaments to heal at the isometric point. So I can kind of show you here. You can see the drill holes for the bone tunnels, and I pass those through first. I get them all ready to go, and then I do the internal joint stabilizer. So here's the pin that's being placed, isometric point. You can see it's going from the lateral side through the flexion extension axis, going directly to where the medial MCL insertion is. And there's a guide to do this to make sure that you're nicely centered on the trochlea. And I usually use the lateral guide and perfect lateral fluoroscopy to get the pin. Then you drill it and place a pin through there. And then what I do is I'll put the plate on the ulna, and prior to connecting all of those together, I'll finish the ligament repair. So you can see here I use some suture anchors, laid down the repair back exactly where I wanted the ligaments, and tied them there, secured them. Then I ranged the elbow, and it was actually pretty stable just with the reconstruction. That being said, because of that extension defect in the back of the capitellum, I decided to put the brace on, or the internal joint stabilizer. So once it's all done, then I'll reduce the elbow, connect these things together, and then depending on the type of injury. So in this case, I wanted actually just a little bit of distraction so that they wouldn't impact too much. So I actually left it as it was, But if you want to increase the stability, then what you can do is compress the joint more than it is there, and then tighten it. And then all of these different hinges tighten, and then I range the elbow and I check stability. And I know we didn't talk about it in the last case, but I always test stability before leaving the OR. So I do full flexion, pronate, supinate, and then full extension, pronate, supinate. And the reason I do both is because sometimes if you have a medial sided injury and you heal or you sort of repair the lateral side, then you're hinging around that point. So it's sort of a center of rotation. So I always check all of those. And what I look for on the lateral is any length or widening of the ulnohumeral joint, so a sag sign or a drop sign. And I look for radiocapitellar sort of sagging. And then on the AP, I look for an ulnohumeral joint incongruity. So is there widening on the medial side? Is there widening on the lateral side? And if I have none of those things, then I'm stable, and then I'm happy, and then I can leave the OR. And so this is what we did. And then I start them on a very similar rehab. I maybe am a little bit more aggressive with the fixator in there. And I wanted her to move because of her, potential risk for HO. I typically keep these anywhere from 3 to 5 months, depending on the stability of the elbow and the risk of and the soft tissue injury. So about 4 months later, she came back, and I took out all of the internal fixator. I left the ligaments, and so here's the fluoro. And she came back about 6 weeks after that. X-rays look exactly the same, and she doesn't have full extension, but she's pretty darn close. She has pretty much full flexion, and she's really happy, despite the fact that she was very reticent at first to come meet me because she'd been burned sort of twice previously. So yeah, that's the case. Greg, maybe do you have any experience with this internal joint stabilizer?
No, so that's I'm just sending an answer to one of the questions. So no, I don't actually have that. And my quandary, Jonah, is something that you actually alluded to, is that, in order to put the internal joint stabilizer in, you have to have the pin at the isometric point. But that's really where you want your ligaments to go back. And so for me, it makes it really, really difficult to I have a lot of cognitive dissonance because I've got the metallic joint stabilizer there, but that's also where I want my anchor to go, where my ligament is going to heal. But I think, though, that, if I think about this a little bit, really the isometric point for any joint is infinitesimally small. So like a 1.6 millimeter K-wire or 2.5 millimeter suture anchor or whatever, by definition, is going to be a lot bigger than the isometric point. I mean, ideally, you put it in concentric with the isometric point. But if you look at ligaments, they have fairly broad takeoffs. And, I think it probably is not of any particular surprise to individuals to find that the LCL with a broad footprint coming off of the lateral epicondyle or near the lateral epicondyle has got some fibers that are more taut in extension and some that are more taut in flexion. The entire LCL can't be isometric. It's impossible for it to do that unless it's just like infinitesimally small, which it's not. So I really like the technique that you showed, Jonah, and I haven't used the internal joint stabilizer. I nearly did a couple of weeks ago, but I managed to get away without it.
I think so I don't use it very often. One, I think that's the number one lesson. One of the things I see is people, and it just happened yesterday, people putting these on sort of non-discriminatory, just kind of anybody gets it, and that's their go-to. And because it does keep everything stable quite nicely, it's appealing. The problem is if you do it wrong or you're a little bit off, then you're creating the old problem with the hinged external fixator, which is if you're not right, then you're not only not moving, but when you move, you're creating instability. So then they get stiff and they're unstable. And that's exactly what happened with this patient that came in yesterday. So I would say in my hands, it's reserved for special cases that are chronic dislocations where even after reconstruction, I'm a little bit unsure of the stability and I want to protect them. Either they've had previous attempts or something like that. And the technique, and it's hard to see, I don't have any intraoperative pictures, but I put that center pin in, and then I get the ligament to kind of heal, or to lay down right around the pin. And I abrade the surface of the lateral epicondyle and the lateral sort of portion of the capitellum so that there's bleeding bone. And I've actually, when I went back, I've gone in multiple times now to take these out, and I look, and it's, the ligament is healed. Just like you said, it's a broad surface. The center of that surface is in the middle of the isometric point, which is what we want. And it's sort of concentric outward. So I think that that's why it works. But I would caution people, just like you said, if you aren't familiar with this and you're doing these sort of on any of these elbows that don't need them, I don't think it's a good technique. You'll put yourself in trouble, and it can be very problematic to revise that after. So definitely a risk factor.
That's great discussion. I'm going to move back to my case, because I'm going to show a slightly different approach to the to that unstable elbow. One that might be more available to the orthopedist in the community who doesn't have a lot of experience with these internal joint stabilization devices. So this is the case again. This is our psychiatric patient, a suicide attempt, and this is now approximately 2 to 3 weeks after the initial surgery. And as both of our faculty mentioned already, it's really important to do a full manipulation under anesthesia, examination under anesthesia, to be sure that they're stable. And this guy was remarkably stable. So what happened in the 2 weeks, I just don't know. But things do tend to swell. The ligaments get a little bit more edematous. I'm not sure. The bad head injury, he pulls the repairs apart, and it goes like this. So this is what I did in this case. Rather than redo all the repairs, I simply took him to the operating room, did a closed reduction. He went back in quite easily. So I think that this was only dislocated at the time that he was in the clinic, where he kind of popped it out when we were changing his plasters. And I just put on a static external fixator. You'll see that we've placed him at over 90 degrees of flexion. We're at about 95 to 100. And I know Greg mentioned this earlier. The static external fixator can be left on for 4 to 6 weeks, and it just holds everything in place really nicely. So if you're in a situation where you're faced with perhaps your case, Jonah, where it's early on and you've done your one attempt and then it hasn't worked and you're forced to go back, this is a really good way to supplement your stabilization of the elbow. In the olden days, when the hinged external fixators were available, we kind of focused on doing that, but they were very, very expensive, and we didn't really like to use them for that reason. And as you mentioned, Jonah, it's hard to get the center of rotation exactly right with those devices, and sometimes you would get it wrong and create more problems than you helped. Whereas with this arrangement, it's just 2 bars, one down the back, one down the ulna. You lock them at 90 degrees, and then you're set to go. So it's hard to do it wrong with this. And I believe there was 1 or 2 studies, I can't remember the authors, that looked at this versus the moving them early with a hinge fixator, and there really was no difference. Which gets us back to that original issue is it's better to have a concentric, stable, reduced elbow than one that's mobile but unstable. So it's good to get them reduced and stabilized. So that's what we did on this case. So we're just going to talk for a couple more minutes on some of the classic literature. Jesse Jupiter is the lead author, as is David Ring, on this article from JBJS in 2002 on posterior dislocation of the elbow with fractures of the radial head and coronoid. So those of you that are participants, you might want to just take a screenshot of this image, or it'll be available on the YouTube video in a couple of weeks' time. But it's sort of the go-to article that talks about what the pathology is and how it got termed terrible triad and so on. This one isn't as much help in terms of management because it actually talks about the terrible prognosis of this injury. I think they had 11 or 12 cases in this series. It wasn't a huge series, but about 80% of them went on to develop post-traumatic arthritis of the elbow. And a few of them required elbow replacements later on and so on. So it's a good reference article. The one that I really like to have my residents and fellows get familiar with is this one. This was from Mike McKee and Graham King, both, and Emil Shemetz. Mostly it was Mike and Graham, Canadian upper limb surgeon, Phoenix. He emigrated a couple of years ago. but he talks about the sort of the steps and management of the terrible triad. Now, during this this fireside webinar, we've gone through all of these, but this is a formalization of the steps. And so in this article, they go through the 5 steps. 1, fix or replace the radial head. 2, fix the coronoid fracture. And 3, repair the capsular and lateral soft tissue injury. So when we talk about fixing the coronoid fracture, we all know that that may just be a suture through the anterior capsule, a crack out type of suture. We're not actually necessarily talking about putting screws in it or a buttress plate, although that does lend itself to it in the odd occasion. So once you've gotten to stage 3, go to 4, which is evaluation of the stability and repair of the MCL. And as Jonas said, 95% of the time, you don't have to do that. You do everything from the lateral side and you fix the LCL and you're good to go without going to the medial side. 5%, maybe a bit more, you have to go to the medial side to repair the MCL, and then adjuvant hinge external fixation if it's residually unstable. So that's sort of the classic way of dealing with it in 2004, which is 17 years ago. But what we actually do in real life is a little bit different than that. So the first thing we do is we don't actually fix or replace the radial head as step 1. What we actually do is we actually look at it and we say, I'm going to fix this or I'm not. And if you're not going to fix it, you're going to take it out and make sure you get all the fragments, and you're going to prep the proximal radius for the arthroplasty, but you're not going to put the arthroplasty in. So you're not going to actually do step 1 fully. You're only going to do half of step 1. You're going to keep your radial head arthroplasty on the back table and put it in at the end of the case. If you're going to fix it, you're going to leave your fragments where they are, but you're not going to actually put the screws in at this stage because you need that space to get to the coronoid and the anterior capsule. I agree with step 2, which is you either fix the coronoid fracture or you do your lasso technique with the crack-out suturing of the anterior capsule. You suture it, you pass your sutures, you don't tie them down, you wait till the end. Then now, once you've gotten your access to the anterior capsule, you now fix or replace the radial head because you're now on your way out. You then can repair the LCL, evaluate the stability, and repair the medial collateral if you feel it's necessary. And then we don't really use hinge fixators anymore, the external fixators, but you can do a static external fixator if you have some residual instability, or you can use one of those devices that Jonah has shown us, this internal joint stabilization device, which I think will probably have a bigger and bigger role as time goes on. So that's what we actually do as an update to that. So any points on that, guys? We have a few more minutes before I do the take-home messages. Greg or Jonah, anything to add?
I mean, I think that was a great summary. I still do use hinged external fixators on occasion. There are numerous different kinds of them. I prefer, if I'm going to use them, to use the ones that are a little bit simpler. Maybe that's because I'm simple-minded. But I actually don't, I don't have a huge amount of need for those. I find that I'm putting an elbow hinge on maybe once or twice a year. I think I put them on a little bit more frequently, maybe 5 or 6 years ago, but I've gone, I'm more likely to put patients, if I'm going to put an X-Fix on, I'm going to put them into a static frame. And I don't have to do that very often either, but yeah, I think I'm looking forward to trying the internal joint stabilizer, but at the same time, I'm not looking forward to it because if I'm turning to it, then it means that the elbow injury is just brutal. And I prefer not to have to take care of a patient with that bad of a problem.
Agreed. Jonah, anything stats?
Yeah, no, I think the take home is bang on. I think one of the things that I found that is sometimes a surprise to people is I never leave the OR with an elbow where I'm not sure of the stability. So if I have a doubt that it's stable, it's going to dislocate. I know because if you try to sort of, oh, it'll be okay, I'll just flex it up some more, or I'll put it in a splint, it always ends up coming back and biting us. So I would say if the elbow isn't stable and you're unable to get it stable in a reasonable, if it's only stable between 140 and 120 degrees of flexion, then that's probably not sufficient. And so I think instead of pretending that it's going to be fine, do something more. And that's when I'll go to the medial side. That's when I'll do the external fixator. And if not, you know, I think test them. If you don't test, now you don't want to test them so that you're ripping your repair, right? You don't have to kind of hyper load them, but I just range them through a normal range of motion. And if I see something that looks grossly unstable, then that's when I decide to do more. And you can get fooled very easily with these, but if you don't test them, you will never know. And so they should be able to get through that sort of gentle range of motion without dislocating. And if they do dislocate, then, you know, sort of have a checklist of things to look for. Is there something in the joint that we forget? Did we, you know, did our repair tear? Does it need a medial side? And if all those things are sort of checked off and they're fine, then that's when external fixator can be a really good. And I'll do static external fixators as well. Like I said, if there's a bad distal humerus joint associated or something else. But the only thing with that, even with the head injuries, is I've had patients hurt themselves with the X-Fix. So you got to be careful. I actually put them in an X-Fix and then I put a cast over it to kind of prevent them from, or splint, you know, to kind of prevent them from hurting themselves more. So just got to be careful.
I think I'd just like to just add one more comment to that, is that 90% of these terrible triads are actually pretty straightforward in managing, and they do pretty well despite the name for them. If you just approach it like we've been talking, like as Greg said, most times you can do it all from the lateral side. You do the steps in sequence and you do them properly. And generally speaking, they remain stable and they do pretty well. So the weird and wonderful case like you showed is an exception to the rule. So we're not meaning to scare anybody off from these injuries, because just to say that if you know what it is and you manage it properly, you're generally going to be able to do a reasonably good job at managing these. So it's just a matter of understanding the injury and understanding the anatomy. So I just would want to leave you all with the final take-home message, which is the goal is a stable, functional elbow. And if it ends up a little bit stiff, so be it. And I think it's a conversation you can have with your patient in advance before you take them to the operating room, that most of the time they will end up with some elbow stiffness, but as long as it's stable, that's what your end goal is. So I'd like to thank Jonah and Greg for participating in this session. It's been a lot of fun. I think we've gone through some pretty important stuff. And I thank the audience, the participants, for the questions. We had about 19 or 20 Q&A questions, and I think they've all been dealt with well. So I think we'll bid you all a good night.